Hi, this is Dr. J. Varma, and welcome to Thermometer. On this channel, I check the temperature of health in the US and around the world and give you expert insights on infectious diseases and public health. This is our weekly episode of Inside Outbreaks. And on these episodes, I review the latest outbreaks of infectious diseases, the outbreaks that you need to know about. And I do this with my friend and colleague, Dr. Jon Epstein, a veterinarian virologist and disease ecologist who, like me, has spent his career tracking dangerous infectious diseases across all corners of the earth. Thanks, Jon, for joining me today.
Thanks, Jay. It's good to see you. It's been a while, hasn't it? I think we've had a couple
Yeah,
weeks off.
we did take a little time off. Of course, outbreaks don't take any time off, but
Ooh, getting right into it. Wow. You
so
just
I thought we
flashed
should
the picture
probably
immediately.
get right into it because we actually have a topic that is not one we need to smile about because it's obviously an incredibly dangerous and troublesome disease. But I do smile because we did take some time off. And what did we return to, Jon? We returned to a disease that I know is near and dear to your work, which
Well,
is
yes.
Ebola.
Mhm.
And so I'll give a brief update, and then let's talk about a little bit about this so we can bring people up to date both about this outbreak as well as advances in Ebola in general. So health authorities in the Democratic Republic of the Congo have declared an outbreak of Ebola virus disease in Kasai Province, where 68 confirmed or suspected cases have been reported. There's 14 confirmed deaths, and this is as of September 4th. 4 of those deaths have been in healthcare workers. They're investigating cases and deaths that present with symptoms such as fever, vomiting, diarrhea, and hemorrhage. And samples that were analyzed at the Ebola Research Center in the National Institute for Biomedical Research in the capital, Kinshasa, have confirmed that it is the specific strain of this virus, Ebola virus Zaire. And sequencing of the virus has already also been done by RNRB, which suggests that this is a new spillover event. So, Jon, I'm going to start first by just showing a quick map that indicates where we are. So, Jon, tell me, what is your first sort of initial reaction to this? Hearing about the new spillover event, hearing about where this is right now.
Yeah, good. Well, so we have been seeing more Ebola outbreaks in Africa over the past few years than in prior times. In other words, the spillover and outbreaks seem to be accelerating. So this is a region of Africa, Central Africa, and specifically the Congo region. And this tends to be one of the hot zones for Ebola outbreaks. We tend to see many of the outbreaks happen in this region of Africa in Central here. So, well, on the one hand, it's not entirely surprising to hear of another outbreak in this location. Kasai specifically is a place that hasn't had an Ebola outbreak in more than 18 years. So this is a province that's not had recent experience with Ebola, but more largely speaking, DRC and Congo are places where we've seen multiple outbreaks historically.
Do we know what the cause of this outbreak is, or what would be your best guess?
So it's always a great question, and it's probably worth starting a little bit with what we know about where Ebola comes from. This is a zoonotic virus, and it's a virus we've known about since the 70s, right, Jay? So there have been more than 50 outbreaks over the years in our experience, and the kind of golden question right now is, where does this virus come from? What are the animals that carry this virus? And in different contexts and different outbreaks, we've seen different types of animals involved. But where the majority of scientific evidence lies today, it is that bats, multiple different species of bats, are likely to be the natural reservoir for Ebola and related viruses. Now, the challenge we have, the trouble we have is we aren't always able to trace back human infection to its source. So when you ask the question, how did this start? I can tell you with high confidence, it started with a spillover from an animal, but I can't tell you whether it was direct transmission from, say, a bat species that's a natural reservoir, or from some other type of animal that may have been infected first and then people had exposure to it. But this is generally what happens: is spillover occurs, there are human cases, and then there's human to human transmission. And I think the other challenge, Jay, is that when we think we're finding the first case in an outbreak, it probably really isn't the first case.
Exactly. And so I want to break this down just a little bit, what this question means and why it's important, which is, why do we get Ebola outbreaks, or what was the cause of this outbreak? So sort of what we call a differential diagnosis, right? Like, what are the possible theories for how this happened? The leading theory is that there was a spillover from a bat into another animal, and then a human came into contact with that animal. I'm going to say these. Let me say these in order, and then John and you react to them.
Right.
So that's number one. Number two is primary source was a bat, but then a human had a direct exposure to a bat that has Ebola, and that's how they got it.
Mm-hmm.
The third possibility is that somebody who got Ebola in the past and survived their infection has the infection still persistent in them and spread it. And we do know this is possible from two routes. So one possibility is a human with persistent infection reactivated the virus, got sick, and spilled it over to a close contact, because we know that there are some conserved sites, like even like the eye, for example, in which Ebola can record. The fourth possibility is that there was, again, persistent infection in a human, and that human spread it through their semen, through their sexual fluids, because we also know that that's possible. So first, John, are those the four possible explanations? And then why, so spillover from bat to animal, and then animal to human, spillover from bat to human, persistence in a human spread through a localized site after through a site because they got reactivation of disease, or sort of more asymptomatic spread from a human to another human via their semen. Are those kind of the four plausible theories?
Yeah, it's really interesting. I think in general, those are the four major pathways. And I think the persistent infection one is really interesting. And so then you start to have to look a little bit at the geography, the history, the epidemiologic evidence. This specific province is a place that, as far as we know, hasn't had Ebola cases in nearly 20 years. And so how long do we understand that Ebola can sustain itself in a person who's been previously infected? Secondly, as I mentioned before, oftentimes when the first clinical case is identified in a clinic or a hospital, that may not be the initial or index case. In other words, it's also possible someone was infected by an animal and then that person never gets discovered. Okay, maybe they get sick and they die and they never report to a clinic, but they have spread it to other people. And it's the second or third or some other case that eventually is the first one recognized. And that murkies the history a little bit for how this happens. But I think in general, the four scenarios you present are among the most likely.
Yeah, and we also have the genetic sequencing data, right? I mean, let's do an incredible shout out, obviously, to Jacques Muyombe and the team at INRB, because this is really quite remarkable to have identified these cases and to have the sequence out like almost immediately.
Yeah, it's a testament to how strong capacity has become in Kinshasa and in DRC in general. There's good laboratories there. I think the majority of this outbreak response have been local nationals as part of the public health response team, as opposed to 20 years ago, where it might have been majority European and American public health support coming in for local government. So that's an incredibly important point to make. So the laboratory data tells us a lot. The genetic sequence can help us relate this virus and this outbreak to other cases within the same cluster or outbreak, and also to historical cases. And that may shed some light on where this outbreak may have originated.
Yeah, and John, you mentioned something really important here, which is that the first, or what's called the index case, may not actually be the first person that was originally infected. And this gets to a dilemma that I've always faced sort of rhetorically in talking about Ebola, which is, I tend to think that Ebola spillovers are inevitable in some ways. They don't necessarily have to happen as frequently, but humans do interact with animals.
Right.
But what's not inevitable are outbreaks. And almost inevitably, the outbreaks of Ebola virus disease basically start in two scenarios. I would say one is, the most common scenario is a human gets sick, they die, they spread it to family members who live in their home. One or more of those family members goes to a healthcare facility, and then they infect other people in that healthcare facility. Because as we know, the sicker you get, the more infectious you are. In most healthcare facilities, not just in Africa, but around the world, don't adequately have the infection prevention and control to stop this from getting spread. That's pathway number one for getting an outbreak. Pathway, and then so lots of people in the hospital get infected. Some of them are healthcare workers. They go home, they spread it to the community. Pathway number two is spillover occurs, person gets sick, person maybe dies. Then there's a burial ceremony for that person,
right?
In which, as part of religious tradition in the Muslim communities in Africa, that people bathe and wash the body, which is, again, when it's at its peak infectiousness. And then that funeral then leads to an outbreak. So we don't know yet, I think, which of those pathways it is so far, right?
Yeah, that's right. I'm glad you brought up funeral practices. That was a major feature of the West Africa outbreak. And I think we learned a lot from that experience where, ultimately there were more than 20,000 cases and a lot of transmission happened during traditional funeral practices where community members have physical contact with the deceased body. And we know that a corpse can remain infectious for days after death. There's enough viral load in the tissue that it can still be infectious. And so that postmortem contact can be a real source. And you're right. I don't know if we have details on transmission in this particular outbreak yet.
Yeah, and for people out there listening or watching, I just want to re-emphasize that point a lot. This is why this is one of the ways in which different diseases require different containment strategies, is because the period of infectiousness can vary a lot. We learned a lot during COVID, for example, that, at least pre-immunity days, before anybody had been most people hadn't been infected and almost no one was literally no one was vaccinated. We learned that people could have peak infectiousness before they even had any symptoms. And the same is true with measles, for example. And it turns out with measles, once your rash appears, a few days later, you are non-infectious. Now, that is very different, however, from Ebola, which is that early on in the disease, you're very unlikely to spread this disease to other people. It's only when you're extremely sick that you become so highly infectious that contact with your physical skin, particularly if an open wound or cut, can transmit the infection to somebody else.
And Jay, let's talk for a minute about the traceback process, the sleuthing part of understanding where an outbreak comes from, because I want to get into a little bit the difference, like how we figure out an index case based on outbreak data and epi data, and then how we trace things back to animals. So you're investigating this outbreak, you're trying to figure out the person who might have been the index case. So what do you start to do when you identify cases?
Yeah. So, I mean, excellent question. I mean, I think that one of the single biggest problems is that, to use an old phrase, dead men tell no tales, right? So if that person is dead, it becomes extremely tricky.
Right.
So the first thing that you do is you try to identify, of course, who do we think the index case is? Who is the first case notified case? Who is the one that we do? We then try to identify any friends or family members of that person and basically just ask as many open-ended questions. Who is this person? What were they doing before they got sick? What types of work do they do? Where do they spend time? One of the good things is that even in some of the poorest communities, people carry mobile phones, right? And mobile phones have data about localities and where people have gone. So you can also obtain the mobile phone for that person, the mobile phone records, and try to figure out where they were. So that's kind of tracking a little bit about who they were. Once you get a sense of who, and you also know the numbers of people they've contacted, which often is a proxy for who they're closest to, then you interview and contact all of those people. Now, the first question you do when you contact all those people is you ask a very simple question. Are you sick or have you been sick?
Mm-hmm.
Because that is the way in which you can try to identify, is it possible that one of those people got Ebola and then transmitted it to them, recovered, or have they already been infected at this point? And so you go in this kind of sequential way where you identify who you think is the first notified case, all of their potential contacts using personal information about their mobile phone data, anything else, interviewing all those other people's, and kind of moving out like a ring to try to understand as much as you possibly can. You would also at the same time try to review as many healthcare records. So hospitals, clinics, pharmacies, because very often people might seek out anti-fever medications and try to use that as a way of what we call case finding. And it's by putting together all of that pieces of information and trying to put dates to it, such as the date that the first person became sick, that you try to piece together how this outbreak may have started, at least as far as the human cases are, and also hopefully get a little information about exposure to animals.
Excellent. So you get data on contacts mapped over a timeline. And with an incubation period, you can start to work backwards and figure out maybe who some of the earliest cases were, or maybe the earliest case. Now, let's add a layer of complexity. How then do we understand what kind of animal exposure these people had, particularly the earliest cases? Let's assume the first case we're aware of is the true index case, the first person to get infected by an animal. If that person were even alive, you would ask them questions about what kind of animals they had contact with in the past say, incubation period, 14 to 21 days, or maybe the last 2 months. And lots of people have all kinds of contact with animals. They keep livestock. Many people go into the forest and hunt. They hunt wildlife, so they have contact there. And the challenge is, particularly with viruses like Ebola that come from wildlife, is that sometimes the activities that can expose you to the virus are illicit and people are reluctant to talk about it. And I'll give you an example. Some of the big outbreaks in the Congo region in the early and mid 2000s were communities that hunted great apes, chimpanzees, and gorillas. And there were massive waves of die-offs. Gorillas and chimpanzees are also susceptible to Ebola. They die from it like we do. And so hunters were going into the forest, finding carcasses from gorillas and chimps and harvesting them. So those are animals that are protected legally and shouldn't be hunted, but yet culturally and customarily, many hunting communities do eat great apes. And so people were getting exposed to the virus and through contact with these dead animals. But they may not be, forthcoming about what kind of animal exposure they had, which can make it difficult to understand. Couple that with now the perhaps bigger challenges, we actually don't know specifically what bats carry Ebola and when. There is lots of evidence from good studies over the past few decades that point to certain species, depending on geography, that have tested positive for Ebola virus by PCR, so genetic material, or antibodies to Ebola. But there has not yet been kind of a gold standard study, a longitudinal study with repeated sampling of a bat species that shows persistent infection and circulation of Ebola virus in a bat population. So it's very hard to know, are people coming into direct contact with bats and getting exposed that way? Or are they picking up, if it's a fruit bat, are they picking up fruit off the floor of the forest that may be contaminated? So again, it's very difficult to understand animal exposure, particularly as you say, when the earliest cases are no longer living.
Yes. And so, I mean, I think, Jon, you've laid it out incredibly well that, and so this is what we think about in an outbreak like that is we're thinking about backwards tracing, which is how did this event happen and start? But the second, and that's the detective work. The second piece of an outbreak is not the detective work of how it happened, but it's the control work, which is how do we stop this from going forward?
Mm-hmm.
And that's what you think about what's essentially called forward contact tracing, which is that, okay, now that we've identified one or more people who got sick with this disease, some of whom, or hopefully most of whom, survived, who did they come into contact with after they became infectious? So we define infectiousness as the period after which people develop symptoms. Then we try to identify all of the people those people may have come into contact with. Again, not before they got sick, but after they got sick.
Mm-hmm.
And those become people who are potentially candidates for one of two things. One, vaccination, because we now have a vaccine, and it looks like 400 doses of the Ervebo Ebola vaccine have already been released into this area. So vaccination, or we have to basically quarantine them, which is take people who have been exposed and say, look, you can't leave your home or you need to be in a certain facility and monitor you so that if you do get sick, you don't spread it to other people.
Yeah, that's right. And that's why, our ability now to contain Ebola outbreaks is unprecedented. I think, following the West Africa outbreak with the, advent and release of these different vaccines, it really gives us some great tools to contain. So you asked the question, can we prevent this outbreak from becoming a bigger outbreak? Can we take a few isolated clusters and contain? And I think the answer is yes. And perhaps the harder question is, can we also prevent spillover in the first place? And where we're challenged there is if we don't fully understand the ecology of this virus, what animals host it, how it's transmitted among wildlife, and what the principal risk factors are for exposure for people, it's very hard then to create interventions that would limit exposure through that. So preventing spillover is an ideal that we want to strive for. I think it's a lot harder than trying to contain an outbreak once we identify those initial few cases.
Yeah. And I just want to re-highlight again the importance of all of these new measures that we had. When I helped work in West Africa during the West African Ebola outbreak,
Mm-hmm.
when I was in Sierra Leone in 2015, we really only had the most basic measures, kind of similar to what we had in COVID early on. All we could do was early identification of cases, isolating them so they don't spread it to other people, identifying exposed people, quarantining them and monitoring them to don't spread it to other people, strengthening infection control in healthcare facilities so that any cases that do slip through don't transmit to other people, and trying as much as possible to promote what's called dignified burial practices, which is for people who do have Ebola, not following traditional procedures. So imagine, making sure funerals are safer. Now what we have is, and then also, of course, behavior change. I mean, everywhere you went during that time, you were putting your feet in bleach and washing your hands in bleach and essentially trying to decontaminate any surface of your body. But now we have a vaccine that is highly effective, particularly at protecting healthcare workers, because healthcare workers die from this because they're exposed to it. And we need them not just as a moral imperative to keep them alive. We need them as a practical imperative, to manage people in these places. But the second thing, we even have treatments available. And monoclonal antibody therapy, MAB 114, has also been sent to treatment cases. So we've got a lot more vaccines, therapeutics, and a lot more knowledge than we ever did before.
Yeah. And getting back to the scenario presented earlier, the idea of a persistently infected person, this one's tricky too, because I guess what you have to do is add in your questioning of cases. Have you previously had Ebola, right? You need to try to recognize people who may have been previously infected to the best of their knowledge, who might be a source of infection, right? And that's
it's an excellent point that you make, John, because I remember during the West Africa Ebola outbreak, because it went on for so long, you would have places that were considered Ebola free and then suddenly had a cluster of cases. And it was only through then that we learned about Ebola being persistent, because nobody could understand how was Ebola introduced there, because there wasn't any infected person from another area that came in. And it didn't appear to be an animal spillover. And that's where we learned that some people can have the virus persist in their body long after they have appeared to recover from the infection and spread it either sexually or because they get a reactivation of the disease and, what's considered kind of an immunologically protected site, and then are then infectious to other people. So let's hope that this outbreak, of course, is contained long enough that we don't have that problem of sort of reactivation or ongoing infection because of persistent Ebola in humans.
And it'll be interesting to see, I haven't seen data on this, but if the genetics of the virus in the current outbreak somehow link to a prior cluster of cases, that might be a clue that this is, retained virus in an earlier case, from some time before.
Yeah, the news report said that they thought it was a new spillover event based on the sequencing. So, which to me would suggest that it's not, but you're absolutely correct. It may very well be that requires further analysis.
If that's the case, then that's really interesting. And so probably what's happening too is, coupled with the human investigations, there may be some wildlife investigations trying to see if they can identify viral genetics in local bat populations, and that might give a clue as to whether spillover occurred locally or not.
Yeah. And so, John, let's pivot a bit. As we both have just highlighted, there is so much knowledge now that has been gained about Ebola, so much capacity that has been built. You and I have had a tremendous amount of experience working on this disease overseas. And where did the money to pay for all that come from? It came from the U.S. government. A huge percentage of it came from the U.S. Lots of different agencies of the U.S. government: USAID, HHS, CDC, the Department of Defense. But now we are seeing we're seeing in this. So this is one of the reasons I wanted to highlight for our second topic. We're seeing this like really bizarre scenario in which we have seeing the efforts of investment and how investment pays off. But in the U.S., as I feared when RFK Jr. was appointed the HHS secretary, here domestically in the United States, we're seeing a full frontal assault on all of that type of investment that has been made over decades in public health. And specifically in the United States, it's on vaccines. So I just want to highlight a few things and get your initial reaction, because there are like too many attacks so far on vaccines. I mean, can you count them all up? There's a lot, right?
It's getting very confusing for the public is what I think.
Exactly. So let me highlight a few of the more notable examples. Number one, changing the label that FDA requires on the vaccine so that it can only be prescribed to people that are considered at high risk of COVID complications. Number two, changing the guidance from CDC to stop recommending certain vaccines, not just COVID, but a whole range of vaccines, changing those vaccine recommendations against the direct scientific advice of CDC experts and major professional societies. Number three, firing top leadership at CDC who opposed these changes that were not scientific. Number 4, spreading misinformation about vaccines and vaccine preventable diseases, such as deaths associated with the COVID-19 vaccine, the role of vitamin A in treatment of measles. Number 5, disrupting CDC's response to large measles outbreaks in Texas and failing to mobilize resources to address ongoing measles outbreaks outside the United States. And finally, states such as Florida now removing their vaccine mandates for attending school, mandates that have been in place for
That one I don't
decades.
understand.
And
Yeah.
other states are doing the same thing. So, Jon, we've just talked about all the successes of public health research and outbreak response and how that's benefiting the DRC. What's your response to all this here in the US?
We're going to have to start applying a little more outbreak response to the United States, is what I think, because
Yeah.
we're going to certainly see more and more of them. All of this, in essence, is creating a lot of uncertainty about what the public should do with vaccinations. I mean, those inclined to be skeptical about vaccines are probably going to be happy to have less mandate and less, directive to vaccinate their families. But it really puts them, their families, and others in their community at risk, because there is lots of safety data, lots of efficacy data, certainly for childhood vaccines and for COVID vaccines. And the fact that guidance is being not only rolled back, but muddied by removing experts and putting people in place who have, political bias and agendas is really challenging. And Jay, what are we seeing now? I mean, what are you supposed to do? Where do you get your information from if you can't trust centralized federal sources anymore?
It's a huge problem. And I chat with a lot of, colleagues of mine who worked at CDC like me for many years, and some who continue to work there as well. And there's a real, quandary, which is, on the one hand, we think CDC is a great and should be a great, incredible institution the way it has been historically. But at the same time, we also have to tell people, actually, the CDC website, at least when it comes to vaccines, is not one that you can trust anymore, and that you need to start looking at alternative sources of information. And by alternative, I don't mean go to YouTube. What I mean is the American College of Physicians, the Professional Society for Adult Medicine Providers, the American Academy of Pediatrics, which is the professional society for child healthcare providers, the American College of Obstetrics and Gynecology, which is the professional organization for people who are pregnant. And finally, Infectious Disease Society of America, which is kind of the broad infectious disease group that covers all types of humans of any age. And thankfully, those societies are putting out information. The Children's Hospital of Pennsylvania, where one of the leading voices on vaccines, Dr. Paul Offit, works, has a whole vaccine information center. And there's a new entity called the Vaccine Integrity Project, run out of the University of Minnesota, that is also putting out information. And this is great. I want to absolutely applaud everybody who's doing heroic work to work on this. At the same time, it's a problem, because you used to be able to say, go to the CDC website.
Right.
Now it's like, do your own research. But we know that every algorithm might, just as much as it might give you good information, is going to give you junk as well too.
Again, and what's interesting is, this is just an anecdote, but I had a friend say to me that their pediatrician was, not recommending COVID boosters for the kids. And when she asked the doctor, when she questioned, well, why not? I mean, that was the recommendation before. And he said, well, look at the CDC website. And she said, well, but you know what's going on at the CDC. So, even doctors who would normally, used to recommend these things, they're now leaning on the CDC. And if your physician is your trusted source of information, and they're getting their information from, let's say, a damaged resource, that's a problem, because people are not going to be able to parse that out. They're just going to be, follow their physician, as they should.
Yes, as normally. And, I do primary care now 2 days a week. And, in general, patients want to hear from you, but they also want to get some additional information. And it was always so easy to say, just go to CDC's website. Now I encourage people to go in New York. I encourage them to the New York City or the New York State Health Department website. Right. And this is, one of the other saving graces here, that a lot of states are banding together. So we have, for example, a whole coalition of states in the Western United States, California and Washington, forming a coalition. And we are, just like people have always been talking about for the past 20 years, that we're splintering into a country of blue states and red states. Public health had been fairly well aligned, but it's not anymore. We're essentially dividing the country now in public health lines based on the information you get and the policies that you have. And that
I know.
doesn't work well when people can travel, move across states really easily and carry diseases with them.
Absolutely. This concerns me the most is that, yeah, you get these consortia of states, but then people will quickly figure out get their information from places that align with their worldview politically. But, with public health, you can't really have two different sets of information and two different philosophies or policies because, like you say, I mean, the disease is the disease and it's going to behave the way it does. And there's free movement. So, our consortium is supposed to be the 50 United States of America. That is really, I think, how we operate best when it comes to public health within our borders. And leaving it to the states is going to create a really difficult situation, particularly when it comes to outbreak control and response.
Yeah, without question. And I think the example that you gave just about a personal story about a physician who was no longer recommending it is the perfect example. Like that is, I will assume, as I should, there's a well-meaning person who's
Yeah.
simply doing what a lot of us do when you're in medicine. There are so much medical information. This is not like it was 50 years ago where one doctor can actually keep up to date on all the information. You cannot. It is impossible. So you have to rely on other authorities to vet and, review information so that you can, on your daily basis, make the best decisions for your own patients. And so it's perfectly natural for doctors to want to defer to an agency like CDC, but now expecting them to keep up to date on all the science, it's just too much.
Yeah, and we'll see what happens in the medical literature. I hope that studies, continue to be protected, isolated from the politics, so that at the end of the day, there's still going to be vaccine studies one could refer to in the published literature that should advise doctors to. I mean, physicians, I know they don't have time to always look at primary scientific studies, but that's another place where historically there's reliable information, primary studies that have been peer reviewed and published.
Yeah. And so before we go for the day, I just want to, put a reminder out there for people, or just to let people know. I will be getting a flu shot this fall.
Mhm.
Generally, I usually wait until October. I think that's just a little bit better in terms of giving protection throughout the season. I will be getting a flu shot and I will be getting a COVID booster. I do not have
I will too.
any of the health indications that the current FDA, corrupted FDA or damaged FDA, says are high risk factors. But I will do it because these are safe vaccines. I like getting my immunity boosted by the vaccine and not by the virus.
Mhm.
We're being exposed to these viruses all the time. There's multiple seasonal peaks of COVID. Sure, we're getting a little boosting from it, but I like getting boosted by a vaccine that I know is safe. And there are a lot more complications to the disease than just a respiratory illness. We know that they can cause heart attacks, they can cause strokes, they can cause blood clotting. So I will be getting them, and I will be encouraging everybody in my family who are now all adults to be getting it as well.
Likewise, Jay, and I would even, bring my kids to get boosted because for the same reasons. I think having boosted immunity, if there's any chance that it can decrease severity of illness, viral replication, any of that, it's worth doing. And the safety profile, I'm convinced, is there. The data supports that, and I wouldn't hesitate to get myself boosted, my family boosted, and that's what I would recommend to my friends too.
Yes, no, absolutely. I just want to emphasize the kids. All my kids happen to be adults. If they weren't adults, I would still be recommending they get it as well. Anybody 6 months and older, please get your COVID and flu boosters this year. It'll be better for your health than not doing it. So, on that note, Jon, thank you very much for joining
Yeah,
me. Thank
thank
you
you,
to
Jay.
everybody out there for listening. And if you like what you're hearing, you want to strengthen public health in the United States, please hit the like button. Please comment, please subscribe, please share these episodes. It helps us tremendously. We're governed these days by an algorithm. So anything you can do to help us with that algorithm is going to obviously help the show, but hopefully more importantly, do something to help public health as well.
And I'll just add, if there are topics you want us to cover, if you're curious about something, put that in the comments too. We're happy to talk about any health related issues that come up, particularly infectious disease. So we welcome comments and input.
Okay, great. Thanks a lot, Jon. Appreciate it. And see you
See you
next week.
soon, Jay. Stay
Bye-bye.
well.